I enjoy doing, put it that way. So I'm going to read the announcements that I read at the beginning of every meeting. The Mental Health Board, who we are. The Sonoma County Mental Health Board is an advisory board empowered to listen to the concerns of our constituents and to help formulate policies that offer a consistent continuum of care for all those with mental health challenges. We are further empowered to advise the County Board of Supervisors on the mental health system of care. The Mental Health Board mission. The Mental Health Board acts as a community focal point for mental health issues and advocates for the development of a community network to promote the following: coalition building that will create a unified voice to impact public policy and awareness, a wider understanding and knowledge of mental health issues, integrity of mental health services, involvement of clients and families in mental health planning. Mental Health Board vision. The Sonoma County Mental Health Board collaborates with the Mental Health Services Division of the Sonoma County Department of Health Services to increase public and professional awareness of persons with mental health challenges and to help eliminate the stigma attached to those mental illnesses. We strive to positively impact the mental health system by listening to public input and working with mental health services to create a policy that will offer hope to families and individuals living with mental illness. So I'm going to go ahead and do the roll call. Betsy Shada. I see that she is present. Bob Cobb.
Present.
Carol West. I don't see her yet. Kathy Smith is me. Marianne Swanson. Michael Johnson. Patricia Gray. I see Carol has joined us. Peter McElweeny.
Present.
Peterson Pierre. Bob Hales.
Here.
Vanessa Nava.
Hello, present.
Nice to have you. And is Annabelle here? Okay. We currently have vacancies in District 2, 4, and 5, and possibly 3. I'm checking on that. Okay. So last month, we had some corrections on the minutes for March 16th. So we have to vote for them. Let's see if we've got a quorum first of all, before we go through that. The quorum is now 8. 1, 2, 3, 4, 5, 6, 7. We have 7 present. So with the vacancies, it seems like the quorum would be less than 8. So we have, let me check and see how many we actually have. 1, 2, 3, 4, 6, 7, 8, 9, 10, 11. We have 11, so a quorum should be 6.
Well, we make it.
Does that make sense?
Yes.
Okay. So do we have a motion to approve
So
the
moved.
March 16th minutes? Bob
So moved.
Cobb. I mean, Bob Hale.
Bob.
A second?
I'll second, so we get it straight.
Okay. So, all in favor of approving the March 16th minutes?
Aye.
Aye. Any opposed? Any abstentions?
I abstain. I wasn't present.
Okay, so did you get that, Tori, that Peter abstained? Okay, and April 20th, I'm hoping that people got a chance to read those. Do we have a motion to approve those? Bob Hale,
Okay, Bob.
second.
Are you sure somebody else doesn't want to? I'll second it in the absence of anyone else.
Okay. Okay, so all who approve,
Aye.
Aye.
oppose? I don't see anybody abstentions?
I abstain. I was not present. Betsy Chavez.
Okay, so Betsy abstained.
I abstain.
And Stevenson abstained. Okay. Okay, so Consumers Affairs Report. Do we have anybody that is prepared to present Consumers Affairs Report? I know Kate is not here. I don't see, well, Michael, is that Michael Johnson? Or-
I'm not sure. Oh, yes,
Okay.
he was raising his hand, so I think it is. I allowed him to talk.
Okay, Michael.
Good evening, everyone. This is Michael Reynolds, Peer Programs Coordinator at West County Community Services. As you all are well aware, this is May is Mental Health Awareness Month. We've had some additional activities happening at the peer centers, some special groups, art groups, some bingo groups, more socialization. At Interlink, we're continuing the remote support groups, the Zoom groups, as well as just hired a certified addiction counselor, an AOD, who will be serving as a peer support specialist. Running, in addition to other things, she'll be running the smart recovery groups. She has a very exciting background in working in shelters and many different populations, so she's a great addition. Dina Joseph is her name. Wellness Center, having a couple new interns on staff, working in the employment training program, where we're helping folks get some additional assistance with the employment training, building skills, building some information for their resumes. Also just did a professional development and team building day, where we did the morning was focused on trauma-informed care, and then the afternoon did a team building activity, sort of envisioning where we're at and where we're going as we look at reopening, potential for reopening. Down at Petaluma Peer Recovery Center, I was just on the meeting with Providence Health, the Community Connection Group, where Cameron presented on the barriers for LGBTQI plus folks in accessing mental health services, and some ways to help bridge those barriers. Out at the EC, began running a shuttle from the Guerneville NCS, the shelter at the Vets Hall, out to the Empowerment Center in Monterey, so folks can start doing some on-site groups out there. Been providing services on-site at the shelter continually. Now that we're able to do the weather's changed, we're able to do some outdoor groups out at the Empowerment Center. We're doing the shuttle to get some folks out of the shelter, out of Guerneville, and out into a new environment to be around some other folks. Next month, actually, I think West County Community Services will be presenting as part of the Mental Health Board meeting. We'll be talking more about the transition to housing program that I sort of introduced last month, the program that's built around providing wraparound services, skill building, resource connection, self-care and coping strategies, and community engagement for folks who are transitioning from the streets into housing. And we're also in the seeking funding stage of that, and we'll be presenting to the behavioral health and CDC this Thursday. Actually, Bill Carter and Tina Rivera, Sid McCauley, and some others will be on that call. So we're excited to be able to start giving some more information about the program and seeking funding for that. The peer support specialist training class is beginning a new round of training. We have 15 folks signed up for that class now. If you happen to know anyone who is interested in being a part of that, this cohort, we still can, I think we still have time to get folks in. If folks are interested, I can put Amy Breckenridge is running that class. I can put her contact information in the chat. And if you know someone who's interested in getting trained, it's a very comprehensive training as a peer support specialist, and then opens up opportunities for internships inside the peer centers for that. So that's what's going on in our peer programs now. I'm happy to answer any questions if anybody has any.
Any questions for Michael? That was a pretty thorough report. Thank you.
Thanks for all your work.
Okay. So, are there any public comments? Okay, seeing none, I am going to do our mental health board appreciation. And this month we're appreciating NAMI, Sonoma County. And I know Mary Frances is there. So I'm not sure that Tori actually got the certificate, so I'm just going to read it. And yeah, I sent it very late, Mary Frances. So
No worries.
you will be getting this certificate, a certificate of appreciation in honor of your years of support for those who need guidance in navigating mental health concerns in Sonoma County. Your support for those who have a loved one with lived mental health experience, those who themselves have lived mental health experience, and the greater community who have questions has been a valuable asset. Over the years, you have provided classes for families and schools, warm line support, and educated all who would listen on different aspects of the mental health system. Your latest work with the Mental Health Board and the jails is an example of your reach. Thank you for all you do. And I really do have a certificate.
Thank you very much. The staff that supports all of this work is going to be thrilled. So thank you very much. We really appreciate this, and we're happy to be part of this community and effort because it's just so needed. You know, we continue to speak with. I'm just amazed that there is not a day that doesn't go by with somebody else newly contacting us who's not heard of NAMI, but who has somebody in their life typically, or they themselves are looking for support. And it's just a constant stream. So I am amazed and privileged to work with everybody here. So thank you.
I just want to acknowledge that Mary Frances working with Carol and I on the forensic and jail services was just incredibly helpful. You know, it was a real honor to get to know her better. And her fine work was really appreciated and made it a really productive experience over the last year. So thanks, Mary Frances.
Thank you, Bob. Thank you. Humbly received.
And one of the site visits that we went to, when we asked if they gave referrals to family members ever, they said, well, it's not that often that we have the opportunity to do so, but if we do, we refer them to NAMI because NAMI Sonoma County is so good.
Oh, well, that's great. Nice to hear.
Yes.
That's really great.
Yes. So
Thank you.
You're very appreciated.
Yeah, thank you.
You are welcome. Well deserved. Okay. So tonight we have a special presentation from the Elizabeth Brown Morgan Center. And I think
Kathy Carol wanted to say something.
who?
Carol?
Carol.
I just wanted to put more praise on NAMI and Mary Frances. I was working with Bob Hale and Mary Frances on the jail work group, and it's just been a real pleasure. And just wanted to let Mary Frances know that I did attend one of her NAMI events, and I just received my Laws We Need to Know book from Aaron Miller. So thank you.
Okay, and I'm just going to share a teeny bit of my personal experience with NAMI. I attended the very first Sonoma County NAMI Family to Family, and it was my introduction to the mental health board. So been a while. So, okay, so back to our special presentation. We have two Julies and Elisa, and they're going to present about the program that it's the Elizabeth Morgan Brown Center presenting on initial psychotic breaks. So I'm going to let you go ahead and take over.
Thank you very much, Kathy, and thank you for having us. My name is Julie Burns. I'm a licensed clinical social worker, and I'm the Chief Program Officer at Aldea Children and Family Services. And with me today, I do have the better of the Julies, who is Julie Faliki. She's a licensed marriage and family therapist and one of our very experienced Solano SOAR program directors. And then we have Lisa Hirsch, Dr. Lisa Hirsch, who's our program director in Santa Rosa. We have been providing early psychosis intervention and treatment in Napa and Solano counties for about 7 years now. And we employ the UC Davis Early Diagnosis and Preventative Treatment Clinic model. So this is a coordinated specialty care model that we will describe all the features of that later on in this presentation. And this past September, we were very fortunate to be working with One Mind and have now opened up a clinic within the Elizabeth Morgan Brown Center, which is co-located with Buckaloo. And we now have an early psychosis treatment program, bringing it to all of Sonoma County. And so today we would like to go ahead and just provide a presentation on early psychosis, and then to provide a little bit more information about our actual clinic and our referral process. So with that, I want to just go ahead and share. The 4 things that we hope to cover today is just why is early identification and intervention in psychosis so important? What do the early signs of psychosis look like? How do you screen and refer to this program? And then what services does Aldea SOAR provide, and who do we serve? So with that, I will start by turning this over to Julie Faliki to describe why this is so important.
Okay, so Julie Faliki, Program Director for Aldea SOAR in Solano County. So a prototypical case of psychosis, positive symptoms are not positive meaning good, but positive meaning things that are added on to normal experience. So hallucinations, delusions, and thought disorders. And negative symptoms are those that are taken away from typical experience, such as lack of motivation, lack of interest, flat affect, and paucity of speech. So can you scroll down just a little bit, Julie? Sorry. So what we are trying to do is shorten the timeline for when the person gets the correct diagnosis. In the United States, clients are not typically correctly diagnosed for almost 2 years, 18.5 months. And in other countries, for example, the UK, Scandinavian countries, Australia, it's 3 months. And as you know, with any disorder, if there's a long time before it's correctly diagnosed, it just tends to get worse. So that is what the effort is towards shortening that length of untreated psychosis. So the at-risk phase ramps up and then to an acute psychosis. And then the recovery phase after that acute psychotic episode is the positive symptoms, hallucinations, delusions, thought disorders remit more quickly, in part because they are responsive to antipsychotic medication. And the negative symptoms, lack of motivation and so forth, take much longer to remit. So it is hard for someone, even with treatment, it takes a while to get back into doing things that they typically did prior to the acute psychosis. So as I said, 18.5 months, and the duration of untreated psychosis, that is the single best predictor of long-term outcomes. And early psychosis is defined as first 5 years after onset of symptoms. So we're trying to shorten that duration of accurately diagnosing and treating so that we can maintain the functioning people already have, their friends and family relationships, work or school, rather than losing all of those due to a prolonged illness and then having to recover those, which is much harder. So this is the statistics that UC Davis Medical Center, the SAC EDAP clinic, they have a contract with Solano County and now with the other counties to provide training and consultation to our SOAR staff. And they've been doing that at my clinic for over 6 years. There's a lot of data collection. So every 6 months after the initial 3.5 to 4 hour assessment, we do a reassessment every 6 months. And this is data from, I'm sorry, this isn't the data, but this shows the relapse rates for duration of untreated psychosis. So if people are diagnosed within 6 months, the relapse, or less than a year or less, the relapse rate at 6 months is almost the same. Whereas if they are identified after a year of onset of psychosis, the relapse rates double. So the duration of untreated psychosis is really a critical factor in recovery. So negative outcomes, why this is so important. The life expectancy of those with psychotic disorder are 10 to 20 years below average. So there's an increase in premature mortality from substance abuse, medical conditions, and suicide, unfortunately. Death rates by suicide, 4 to 13%. Most common in the early phase of the illness. And then a very high unemployment rates, high risk for homelessness, poverty, poor quality of life. And which of course only makes the illness worse. And then the economic burden is astronomical because of all of that above. $37 billion for direct healthcare costs, hospitalization, medication, indirect costs, high unemployment, and caregiver burden. Those diagnosed with schizophrenia had a cost of care that was 80% higher than the general Medicare population. So huge, huge human and huge dollar costs, societal as well.
And just to add on to that, in terms of the cost benefit, 30% of individuals who have persistent illness and who don't respond adequately to the initial treatment, the costs for those treatment resistant cases are between 3 and 11 times higher than those who have schizophrenia and who do respond to treatment. So this, again, is why it's so important with psychosis to intervene upstream as early as possible in the course of the illness.
So So UC Davis, who I said provides all of our training and consultation. What we use as a screening tool is the PQB prodromal questionnaire brief. And they have an effort to use this screening tool widely. And their results showed that just providing provider education alone had much less robust results than actually giving a potential client the PQB screen and having them go ahead and answer those questions themselves. They had a much higher rate of identifying clients with potential psychosis. So 3 times more with them actually, because there's a lot of questions that people wouldn't normally ask. So it's an opportunity for the potential client to actually read something that says, oh yeah, this is what I'm experiencing, as opposed to just provider education, because they may not ask those types of questions in a typical setting. So this is the coordinated specialty care model that we use, which is the early psychosis model. There are different models that early psychosis programs use. Ours is a team-based approach. So we do a phone screen, which is about 1.5 hours long, an assessment, which is 3.5 to 4 hours long, because we really want to be sure the diagnosis is correct. And then we offer, if they do qualify for services, individual and group therapy. Our groups are peer groups. We have substance abuse. So we have peer groups for minors and for adults. We have a multifamily group where all the families get together and meet other families and also receive education and do group activities, and family support group, which is just the adult caregivers or support people for that client getting together and forming mutual support and also getting a lot of education. We do case management. We have medication services within our program. And we have a family partner who is a support to the family and also does education and support because it doesn't help for someone to get out of their normal activities of school or work. So we want to support them in getting back into school or work or continuing in school or work. At my site, she does a lot of work with educating clients and families about what their educational rights are, for example, how to get a 504 or an IEP so they can continue school in a modified way, and also help them get into jobs so that they're continuing to be a part of their community and not, just staying isolated and not participating.
And I do want to make sure we just emphasize that this is very different from standard community treatment. So Julie Fleeke did list a really robust scope of services that are provided, but that's not just a menu, that's the way that the whole team functions. So this team-based approach and this emphasis on shared decision-making, what it looks like is we have our psychiatric nurse practitioner, our peer support, our therapist, our supervisor, our supportive education and employment specialist, everybody coming to the table every single week, staffing each case, talking to the families, representing that family voice in those coordinated specialty care team meetings, and really doing an exhaustive review of the records, of the trajectory of their illness, and then of their current resources and what supports the family system needs, or an identified support person who might be in that person's network. That all is really part of this shared decision-making model that differentiates this from standard community treatment.
Thank you. And we tell the clients that and families that from the beginning. Our age range at my site is 12 to 30 years old. For clients, and actually what's at the center is the client and the family, however they define it. So it's super important that they have a support person who understands their illness and can be as supportive as possible, because it's very confusing, not only for the client themselves, but for their family or support people or their close friends as well, to figure out what they're experiencing and how to help them. what do the early signs of psychosis look like? So marked changes in behavior, thoughts, and emotions. So perceptual abnormalities. And psychosis is on a continuum. So I'm sure we have all had the experience of thinking we see something, thinking we see a snake, and it's usually, just a hose or a rope or something on the ground, or thinking our cell phone is buzzing and it's not. So it's a part of human experience, but this is, when it moves towards psychosis, it's much more marked. So unusual beliefs and ideas, delusions, a lot of fear and suspicions, disorganized speech, odd behavior. And it typically develops between 15 and 25 years of age. And the thought is that with the brain maturation and the influx of hormones, that somehow that's linked to the development of this disorder. And as I said, it's on a continuum. So there could be experiences we all have where we think we hear someone calling our name, or we think we see something and then we look again and it's not that thing. So they could have no distress. It happens very infrequently. It doesn't really impact them. And then as it becomes more distressing and more frequent, and starts to change their behavior, then it becomes more on the side of becoming a disorder. So increasing frequency, maybe it was weekly, going to daily, increasingly distressed, and it just seems more and more real. And starts to affect their behavior. For example, if they believe, for example, that people are out to harm them, they may stop going outside, or throw away their cell phone if they think that someone's listening to them through their cell phone, that kind of thing, where it starts to become really real. And then fully psychotic is where it's really distressing, really scary and upsetting. It's happening a lot, and the person is really convinced that it's real, and it affects their behavior in all kinds of ways and impairs their functioning. If they were working, going to school, seeing their friends, a lot of that stops. They may isolate. They may feel overloaded because they're getting a lot of, they're hearing a lot of things, or seeing a lot of things, or feeling things on their skin, things like that. And they want to isolate because it's overwhelming and they don't know what's going on. Now, this is an example from one of our trainers that she saw a vision of her grandmother who had passed away. And it was right after her grandmother had passed away, and she was in her grandmother's house and woke up and saw her grandmother standing in the hallway smiling at her. And that was very consistent with her family's beliefs, and she got a positive feeling from it. So it's always important to see, is this, within that family and within that culture, is this a normal experience? And it didn't upset her, didn't change her behavior. But some people can have visions of what they would interpret as ghosts, and it becomes scary. They start to not be able to sleep. They can't get up in the morning because they're not sleeping. No one in their family believes in that or in their culture. And then something like that could become more frequent, more distressing, could be threatening and very scary. And they may change their behavior, not be able to sleep, not want to go in a room where they have that experience, that kind of thing. And then fully psychotic would be that is really distressful. It's happening really a lot. They're completely convinced that it's real, and they've completely changed their behavior and functioning. So important things to consider: developmental norms, because if a young child has a imaginary friend, that could be completely normal for their age. But if someone who's, say, 21 has imaginary friends, that wouldn't be considered developmentally normal or typical. And then again, the cultural or familial context, what is within norms for their culture and family. And then environmental factors. If someone is afraid to go to school, maybe they're being bullied, or maybe someone's following them home from school and threatening them. So it's important to understand what the context is of their beliefs and feelings and behavior changes. How to screen and refer. So again, as I said earlier, our prodromal questionnaire brief, PQB, is something that we give to potential clients ages 12 and up, and they go ahead and answer it themselves and give it back. And then we look at those answers and how upsetting that experience is to them, how distressing. And it's not a diagnosis, but a score of 20 or higher indicates that they would need to be evaluated. So typical questions: do familiar surroundings sometimes seem strange, confusing, threatening, or unreal? Yes or no. If yes, I feel frightened, concerned, or it's caused problems for me. Strongly disagree, all the way to strongly agree. So each of those is rated with a score, and there's, you know, a number of questions, 21, and then there's a score at the end to indicate if there's potentially an issue. And then that can be sent along with the referral form to SOAR. You can also always call and just do a verbal consult about a potential client. And then we take it from there, and you don't need to go through Access. So it's a direct referral. And we take it from there with contacting the client and getting any information on the referral that we don't already have. And then we have a phone interview that's about an hour and a half long, where we talk to the potential client as well as like a parent or a referring party to get as much information as we can to see whether they actually qualify for the lengthy assessment. And if the client agrees to a phone interview, then we ask that you complete the referral form, or get permission for us to contact them, and then we would complete the referral form with them. And if they don't agree, then don't send it, because they're not going to want to speak to us if they don't agree. So just try to revisit it at a later date.
Yeah, another thing we do here is we, you know, it says it's common for families to have concerns about this process, talk to them about these concerns and problem solve. So Julie mentioned earlier on, if you identify a case, if you encounter somebody and you have questions, just call the clinic and consult with our program. We can help give ideas on how to frame the referral or how to frame that conversation. And there's a couple examples here in the next couple slides that Julie is going to review about some of the language to choose so that it doesn't feel more stigmatizing, or it's not a turnoff to treatment. And we can actually get people to respond to, hey, my experience has changed.
So those are some proposed ways, scripts that I believe we're gonna send you this PowerPoint of ways to present it to clients. I'd like to connect you with Aldea to learn more about your experiences that have been bothering you. They do specialty services and assessments for youth and young adults experiencing these types of changes. And it might be helpful to understand what's going on. And can someone give you a call? And these are just things of people that people may say in response to you offering a referral. You know, psychosis is so stigmatized that people really don't feel comfortable much of the time in seeking support. So as I said earlier, you can call us anytime just to consult about whether, without filling out the paperwork and so forth ahead of time, about a potential referral. And we have to confirm first that basic criteria is met for the program, like the age, the residence. Yes, we do provide services in Spanish. And I'm sorry, that was it from the chat. What services do we provide? Who do we serve? So eligibility is 12 to 30 years old. So again, we're focusing on that early psychosis, and that is around the age that it typically occurs. And you saw the earlier slide, 15 to 25. IQ over 70, because we do cognitive behavioral therapy for psychosis, the IQ needs to be high enough to participate in that in a meaningful way, and no illness or injury affecting cognition, and substance use acceptable, but not if it's to the point where it would interfere with treatment. And we accept those who have an onset of full psychosis within the past 2 years, or attenuated positive symptoms. So if someone had positive symptoms such as seeing or hearing things, but not to the point of being fully psychotic, then that could be of any length. Or recent deterioration in a youth who has a parent or sibling with a psychotic disorder. So that would be the genetic risk.
And as Julie mentioned, those people who are most appropriate and will benefit the most from this particular evidence-based program would be those who have caregivers or a support system who are also willing to participate in their treatment and who will benefit from that full scope of program supports that we offer.
Yeah, it's super important to have that support and have someone in your life who understands what you're going through and how to help you, and who gets all the education from the program about psychosis.
One question that we also receive is about pay. So as we have started up this program in Sonoma County, we received funding through a One Mind Aspire clinic. And as I said, we are within the Elizabeth Morgan Brown Center. So currently there is no cost associated with this. If they have Kaiser insurance, we may have an opportunity to bill Kaiser, but other than that, we're currently in a ramp up phase right now. Eventually we will bill Medi-Cal, but for now, there's no cost associated with it. As we talked about the coordinated specialty care model, just what that looks like, a little bit more about this. As Julie mentioned, we have the client and the family in the middle of this entire support network. You know, the community and outreach and education, you see this bubble on the far right, that is a huge component of this particular program, is providing education about early psychosis, destigmatizing these conversations about mental health and about psychosis. And so with that, Lisa Hirsch on the line, she has been conducting a series of outreach presentations to schools and to clinics, and it would be happy to, if there's a particular population or program or organization that you would also like to receive a presentation at, she can definitely coordinate that. And I know we've got something with NAMI scheduled. And so that is a huge part of increasing our referrals and decreasing the stigma around these particular conversations. Julie, I don't know if you want to cover anything else on this particular slide before I move on.
Just that we tell the clients and families that we are a team model, and that we will be, whatever team member they're speaking to will be in communication with the other team members, so that we have a full team supporting the client's recovery. And also really important outcomes evaluation that we do reassess, as I said, every 6 months. And we do have, you know, concrete evidence that is an effective program for those who participate. And we always do relapse prevention work before people leave the program. They can stay up to 2 years or longer. And crisis management is also, you know, developing safety plans and connecting people with services as needed. But we do try to prevent that as much as we can. So the process is we identify a client for a phone interview, and then send that information, the PQB and the referral form, to Aldea, and the program coordinator follows up right away. If they're not appropriate, they'll notify the client and the referring party. If they are appropriate, we'll schedule first the phone screen and then the initial evaluation with the clinician. And if they're eligible, they can receive services for 2 or more years, depending on their individual needs. And that includes medication services. And if not eligible, we still provide feedback to the client. So what we do is go over all the results of the lengthy evaluation with the client and family, whether they qualify or they don't qualify. So explaining the reason, what diagnosis they have, why they have that diagnosis, and explaining what the services are. And the same with if they don't qualify, explaining the diagnosis, how we came to that, answering any questions, and referring them to an appropriate place.
So with that, we will be providing Tori with the slides as well as a copy of the referral form and the PQB, just so everybody who's attended has that available to them. And then it will have all the contact information here. If there's other questions, if there's anything you want to consult about, or if you are interested in any other outreach presentations.
Just a question, Julie. Have you been looking at or studying adverse childhood experiences in the population during research?
Are you asking Julie Burns or Julie Fulicki?
Julie.
I'll just answer, yes, adverse childhood experiences, a part of what the clinicians are trained in is trauma-focused cognitive behavioral therapy. So they or receive that training, and also, this is not specific to the ACE, but it says about trauma focused, and then they receive 12 consultations over the period of a year for actual clients they're working with, doing trauma focused cognitive behavioral therapy with those clients, so that they are using it to fidelity. So yes, there isn't always, because there can be a number of factors that go into psychosis, including genetic factors, but there often is trauma. And that's something, after there's some stabilization of the client, that we would work on if they are interested, if the client is interested.
And components of the ACEs are built into our assessments as well. We also use the CAN, so the child and adolescent needs, to collect data and then measure improvement over time. And then Aldea and the work that we do here, we strive to be a trauma-informed agency, really top to bottom, left to right, and really meeting clients where they're at, being very, very flexible with understanding client needs and systems and barriers, and working really diligently to meet families where they are at.
One unique factor at the Sacramento clinic is you issued iPhones to some people who are on medications to give complete information and studies. Is that correct?
I didn't catch the beginning part of that conversation.
Oh, about the use of iPhones to provide increased care to young people who have had a first psychotic break, so they can monitor and report back how they're doing on medication. Is that correct?
Well, we did a
Study.
SACEDEC, yes, I believe they did that, but they did a MOBI study with our clinic in Solano, where that's part of it, where they are, asking them how they're feeling, or did they take their medication, or did they get outside, and so forth. And then that would be fed back and reviewed with the client in their session. And now we are moving towards a tablet-based reporting system with the clients. Pandemic makes it a little more complicated, but we're just starting that now with them reporting their symptoms, because it's best if the client becomes their best observer. They start noticing their symptoms and what makes them worse, what makes them better, noticing their stress levels, how they're responding to medication, everything. So it's really just training the client and the family to really notice what the changes are and what they're related to, so that they can be more, develop more self-care and do the things that are best for their recovery.
Thank you.
I have a question regarding the age group. 12 to 30. How did you arrive at that age group? And my understanding is that talk about early detection and connecting to resources. So am I to believe that people over 30 do not have breakdown for the first time and need connections? Can you clarify that for me, please?
Are we talking about the age? I'm sorry. Are we talking about the age group?
Yes,
Yeah.
the age limit, you said it was from 12 to 30.
For the program to be capped at age 30, Julie, why is that?
Oh, well, you know, I believe the SACIDAP program goes to 40, but it's really just what was offered to us in terms of our MHSA contract. And I think they're trying to gather the most frequent, because it most frequently occurs, you know, between 15 and 25. So we go down to 12 and then to 30, but it's really just a decision made at a higher level in terms of what would capture the most people. But I believe the SACIDAP program actually goes up to 40.
It's either 35 or 40. And I think what, you know, the limitation is that there's a finite amount of resources. And so for the purpose of this particular program, when we look at the data about how many new cases of early psychosis there are per 100,000, just in the Medi-Cal population, it's like 242 individuals per 100,000 have a new case of early psychosis. So, you know, and again, that's just in the Medi-Cal data. And so when we look at what are the resources and where are those resources going to be best focused, we're looking for kind of like where the population is skewed for the positive outcomes. And so we know that this treatment as applied to this population is going to have the best outcomes for this group of people. So that's why we do have to limit that criteria.
Thank you.
You have a question, Carol?
Yeah, I was wondering if you use psychiatric advanced directives or RAP, wellness advocacy plans, as part of your relapse prevention and crisis management strategies?
That doesn't sound familiar. Relapse prevention is, for us, we use a format that was given to us by UC Davis, and it's really just making the client and family as aware as possible of the really subtle signs of that they would be heading towards relapse, and really identifying those so that they don't go into a full relapse. So this is something that's explored throughout treatment, but actually we formalize it in a wellness plan before they leave, of really identifying what all those subtle signs are.
But in terms of an actual psychiatric advance directive, Carol, I don't think that that's something that the programs are currently using on a formal basis. Employing the client's wishes in their feedback, and that guides the treatment. But that's a great point. I think for the programs to go ahead and look at that as a formal process of implementing that to make sure that their wishes and their psychiatric care is really front and center. Should there be an issue of crisis, the wellness plans and the crisis prevention plans that are put in place are not that formal legal document, right?
Right. Right. It just kind of maybe planting seeds, because there seems to be some initiative at the state level, and certainly MSHA innovation funds are being used in Fresno and Monterey, and so there's five counties that have got together that are kind of spearheading this effort. And it seems like you're doing the work anyway. You are already asking the individual to watch, and family members to watch and be observant of those small things that give an early indication that something's maybe not right. Yeah, and then kind of having a point person that you identify to potentially help you if you feel like, you know, your symptoms have gone to the point where you're not making good decisions for yourself.
Yes. Are there other questions or comments?
I have a question.
Yes.
So I did see there was a question about there being bilingual support, and the answer I did hear was yes, but is it bilingual, bicultural, or is it how? And I asked this because I have my little brother has schizophrenia, and it was diagnosed a number of years back. My parents are more comfortable in Spanish, and I know there is, as we all know, there's the lack of programming specific to Spanish speaking families. And I guess that also brings me to my next point, is that I'd really like for the county to support programming that does have bilingual, bicultural support, because in the past I've been fortunate enough to work with a program with NAMI. It's called Family to Family, and it was in Spanish. And I believe he was the only one, and maybe the only one at this point, to offer bilingual support to families. And he was bilingual and he was bicultural. And he may have been more proficient monolingually in Spanish. I'm not really sure. However, the fact is that that no longer exists because they lost that employee, unfortunately. And it's been it's been a struggle to keep momentum, to continue have programs be consistent and continual so that families really feel support. So I wanted to make sure to make that point, and also to understand what programming happens within Sonoma Valley specifically. So I might have covered too many things, and I can repeat.
Let me answer your questions before the last one, which is that we have staff psychologists from UC Davis who provide training and consultation to us. One of those is specifically bilingual, bicultural training. And she actually made a 1-hour psychoeducation specifically for our monolingual parents, because at the moment we don't have a bilingual therapist, although we have 2 bilingual program coordinators. So she made this lovely video that we show to all of our monolingual Spanish parents, which we've gotten wonderful feedback on, because they finally understand in their own language psychotic disorder. So it's absolutely wonderful in that regard. So it's something that's always in the forefront of our mind, and we should have a bilingual therapist fairly soon, but they are at a premium, as you know, so there's a lot of competition for bilingual therapists, but we do get as many bilingual staff as we can. But
just to clarify, Julie, you're speaking about your Solano program. So when we're talking about the actual Sonoma program, we've been fortunate that we've been able to leverage our regional infrastructure to support the different programs, and also to take the benefits of this new Zoom ability to bring families together and to bring programming together. So we do have a bilingual therapists. So we're currently ramping up right now in Sonoma, recruiting for a full-time bilingual therapist. We do have bilingual staff on hand, so these are going to be our actual program coordinators. But then we also use the bilingual staff in Napa. So we have a couple bilingual therapists in Napa who also are providing services to our Sonoma team and are able to serve the Solano team when there is a case where you have a monolingual client. So that is front and center of our priorities, Betsy.
And I also want to, I guess, if I may, I'd also like to recommend we connect with Doctora Daniela Dominguez, because her program at University of San Francisco is specifically providing incentives for bilingual, bicultural folks to join their master's program, to become an MFT, licensed MFT. So there may be some opportunities I would say, and they're recruiting heavily here in NorCal, specifically Hillsburg and Cloverdale, and that area, because they just know that that's an immediate need, as we all know. So I'll make that connection. And I did see, Mary Frances, that you responded. Thank you for that. I'm glad to hear that there's bilingual support on your end, and let's connect. I'd love for this presentation to be offered in Spanish, and you may have it already, but I would say a lot of our families don't understand, they really need from the very get-go how to start identifying how to support their family members. And there's programs that I know that exist that have a good following in terms of parents, new parents, and longstanding parents. So like, for example, On the Move has several programming throughout the Sonoma County, I believe. And so that would also be very helpful.
And that education, psychoeducational video in Spanish by our bilingual bicultural consultant from UC Davis Medical Center, Saki Dapt, is also available to the Sonoma program. So.
Okay, any other questions? Okay, I don't see any other attendees with questions either. So thank you very much for your presentation. It was very informative, and look forward to seeing the results of your work here in the county.
Thank you very much for having us. We appreciate it.
Okay. So, Bill, do you have a report for us tonight?
Hello, yeah, I've got a hodgepodge of things. So in the world of new programs in the area, we have one that is a partnership with the Sonoma County Office of Education. They applied to the Mental Health Services Oversight and Accountability Commission a little over a year ago for funding to support a project to promote mental health services on campuses. They were not funded in the first round, but with additional monies available, they were recently notified of an intent to fund their project. So that'll be a nice set of school services that'll be coming. It'll largely be operated by SCO. We will partner with them to work with kids who have needs that are beyond the on-campus mental health services. We have submitted 5 MHSA innovation projects that went through our stakeholder and selection process, and we're again, this is work that started a little over a year ago, but we're beginning to get notification from the MHS-OAC regarding approval to move some of the projects forward. So the Early Psychosis Healthcare Network, which is associated with the program that just presented, is a project that has funding moving forward. And then Nuestra Cultura Cura, a coalition of local entities that are doing outreach to the Latino community. And we hope to hear on the remaining 3 submissions sometime soon. I've presented briefly on the substance use disorder system mapping and planning project that we've contracted with RDA to lead this process. The goal of this project is to go through a process that reviews local data, the current local service system, and stakeholder input to outline what would be an ideal substance use disorder system for the community. And we'll use that information as we look at opportunities that may come our way to expand SUD services through opportunities like an invitation to join the ODS waiver, the Measure O money that is set aside for substance use service expansion as well. So they're completing the data gathering and initiating the focus groups. So some of you have been contacted for the focus groups. It's a relatively small focus group opportunity. It's fairly large for a project, but when you look at the number of folks who are interested, we certainly can't get everybody or even a large number of people in the focus groups. So we've distributed a survey so that anybody who has interest has an opportunity to submit input that will go into the final analysis. The psychiatric health facility, the PUF, we're getting closer to nailing down an opening date. At this point, the projection is it will complete its licensing and review processes in September, which would have an October opening date for that. On the budget front, so we are in the last month of the budget development. This is a different budget process than we've experienced in the past. I think largely driven by the fact that Measure O money is in the mix now, and there need to be decisions about how it's used, and so there's a lot of decision making and a lot more resources to consider. And then it's a different board. We have a new chair and a new member of the board. Our first public presentation was April 26th. The next set of budget hearings in which there will be public hearings are in June, I believe the 15th and the 22nd. At this point, I have no information to share about the developing budget. I can tell you I hope I'm not wrong, but I'm not worried. On the other hand, it's not developed enough to share any information beyond that was shared at the April board meeting. One thing about the budget that is relatively new is what's going on with the state budget. So the governor released his May revise on the 14th, and there's just a lot of activity there, a significant amount of investment in a number of areas, one of which is behavioral health, and significant investment in one-time projects. So facilities and infrastructure, workforce. There's a couple of large school service opportunities that are coming forward as well, so that in addition to the MHS OAC project that I referenced, we should be optimistic that other funding will come to expand school services. And I encourage you to look at the revise. It's information that's hot off the press. There's no direction yet. All we can do is follow the information, begin to organize ourselves to respond to funding opportunities that come our way, so new funding that comes to Sonoma County, or to be ready for competitive processes that may come out of this. In the world of staffing and personnel, Tina Rivera was placed in the interim director position for the Department of Health Services and Community Development. We have a new manager for our crisis stabilization unit. So Angel Cassidy has joined us and is in her first couple of weeks with us. Her being on board allows Sid McCulley to return to her position as section manager. And Diane Madrigal, the section manager for our substance use disorder services, has announced a retirement. So she will retire from the division at the end of this month. We'll be saying goodbye to her. So that's my laundry list of things that are happening in the world of the Behavioral Health Division.
Carol. You know what I'm going to ask?
I'm looking, I think there's going to be opportunities. I need to see how they shape up. But yeah, a lot of the workforce development information references peers. What I'm looking for is opportunity to not just do training, but I'm hoping for opportunities to create positions. So I'm tracking that.
So that would be helpful for the implementation of the certification process, potentially.
I hope so. I hope that because as you know, Carol, but others may not, the compromise that everyone made last year to get the peer certification bill passed, which creates a peer certification that creates an opportunity to bill for peer services in the Medi-Cal system, came without money. So there was no money to fund the certification, and there is no agreement yet in the Medi-Cal waiver to fund the services. But my hope is that with the considerable investment in workforce that comes, there's going to be resources to kickstart that.
And do you know at this point where the funding is coming from for the peer services, the peer centers? My understanding is that it will not be MSHA again this year. So the question is, where is it coming from? And will there be a budget amendment to the process to create sustainable funding for the peer centers?
I know that's it's the intention of the advocates I work with to advocate for that. I don't know of any specific initiative to do that, but I am very interested in looking at we all are very interested in looking at these new workforce investments to look for opportunities to find money to support that.
Is it Project O or Program O, funding quarter-cent tax? Is there any possibility for sustained funding for behavioral health? I know they have categories where the money's supposed to go, but is it possible that you could hire people or develop new programs and count on sustained funding?
Did you start by mentioning Measure O?
Yes. But they have different allocations.
Yeah, so the decisions about that are in process. Roughly, as I described in the past, roughly 53% of the funds support existing budget items, right? So they are part of the process right now is to correctly place those funds and then see what happens relative to the new programs. There needs to be decisions about how to plan that. So that's what the Board of Supervisors ad hoc committee is looking at. They're looking at the money to support existing services. Is it going in the right place? Are we putting it where we are supposed to be putting it? And then they are asked, they're collecting information about what are the expenditure areas that would support new programs, how much money is there for that, and then they're establishing their priorities and parameters.
I see Michael's hands up.
Michael?
Reynolds?
Yeah, as talking about Measure O, is there any update on the timeline for the sitting of the Oversight Committee?
No, I know that, I don't know that. I know that the applications are in, and they're establishing the review process to go through the applications and make decisions about placing. But I don't know the specifics of the process or that timeline yet. And be aware that just to make sure everybody's expectations are lined up, this oversight committee is going to look at things, how things are being done. They're not going to be doing planning. They're not talking about new programs or how money is going to be spent. They're looking at everything retrospectively.
Got it. Thank you so much.
Yeah.
Okay, any questions for Bill? Okay. I don't see Maria, our peer coalition intern here. So I'm going to move on to other reports. We have Bob Hale. I don't know if you are feeling ready to present on the site visits. I know
Yes.
that Elizabeth from Progress Foundation was hoping to be present, and I don't see her. I don't know the phone numbers, but I don't think she's here. But
I could present if you want me to, and I could also present the Buckaloo.
okay, why don't you go ahead, because we don't want to leave it forever.
Well, the Progress Sonoma, Kathy and I conducted a site visit. It was an experiment to see, can you conduct a site visit via Zoom? And what was really cool about that is one of the staff had a little iPhone and she walked us through the whole building. There we are sitting in a Zoom, and here comes the video showing the bedrooms, the outside, the kitchen. It was really pretty neat. I mean, I was very impressed. But it's basically an 8-bed facility, 10-bed facility, has 5 bedrooms and provide a whole range of services. And I think what's important, the client rooms were comfortable, the smoking area they had screened from the rest of the area. They had a recreation center. Staff have created an environment that the clients felt safe, and they were very open, and obviously things they would want is more resources, more housing, which is a theme that all of these programs has provided. And the staff is very positive in terms of working there. There's very little staff turnover. And Elizabeth, who she runs both the Napa and Sonoma programs, was helpful and was there. And Lizzie was the one who showed us around. But we asked a whole series of questions, which are on our program staff survey. And I think, to make a long story short, I found an enthusiastic group. They were very well organized. They were very detailed about what they presented. We asked quite a few questions, and we prepared the program site visit report, which summarizes that. So basically, it was a crisis residential treatment program that is basically usually average about 8 patients or 9, and the average length of stay is 7 to 14 days. So it was really well staffed and organized. So that was, Kathy, you were.
Yes, so I was impressed with the tour that we had, and it they presented it as an alternative to hospitalization. So kind of a step back into living their life in the community rather than hospitalization. And they seemed very knowledgeable, very client-centered, and it looked like a really good environment.
Yeah, I didn't see any negative things. But it was impressive being able to see everything rather than hear what they would say about something. We actually saw it, or the bulletin board, saw the actual kitchen, saw the refrigerator, saw where they staffed the food where you could walk in. And we were able to see everything, and inside and outside. Very well maintained facility.
Yeah. And I was impressed with the way they handled food and snacks. Nothing was locked, and people had access to snack drawers and actually all of the food all of the time. And if, my question was, well, what if somebody, eats part of dinner? And they said, well, then that's an opportunity to just have a discussion about, well, what do we do now? And, nobody was going to starve, but they might have to change the dinner plans. So I thought that, that was an interesting way to handle it, and a way that it's a real life, situation. Carol, did you have a question?
Yeah, it sounds like a really nice place. I'm just wondering if you had opportunity to, or whether you asked for interviews with people who live there.
We're working on that. I asked, I haven't heard, but that is important to get one of the consumers to be interviewed. I agree.
And
confidentiality stuff we're concerned about.
Yes, and Elizabeth, not sure. It was Elizabeth and Lizzie that were involved, so I'm not sure which one it was that was willing to be here and talk to us as a group when we presented this, but the timing just didn't happen correctly. So we can get an answer from her and recontact her.
Our goal, Carol, is to have a consumer complete the survey, not just complete the survey, if possible, to be interviewed by Zoom, but just the details of getting that done and protecting the confidentiality of the person was our main concern.
Yeah. Well, just kudos to you guys doing a site visit via Zoom. That's very creative.
The Buckaloo programs were also creative. They didn't do a Zoom, but they had a program, they had pictures of everything, all their facilities. What I was originally going to just wanted to see is McBride and the Manor House, but they showed us their apartments and then the North Point Parkway facilities. And so we saw it's a very big program. The budget, you can look on the web, is $18 million. Buckaloo programs includes principally is Marin County, Sonoma, Napa, and then they have some other county sites, but those are the big three. And so they present an overview of the Buckaloo programs, and with a focus, it was all on the Sonoma program. And so to summarize that, they include drug and alcohol treatment and detox facilities. Their Sonoma County patients would be referred to. They have a Helen Vine Recovery Center, which Sonoma County has purchased a couple of beds. They have employment services for clients in coordination with the Department of Rehab. They have system navigation, family support to all Sonoma County residents. They have a partnership with LDA Children and Family Services. And we heard One Mind for Elizabeth Morgan program. That's on the early psychosis. So that's one of the contacts from Sonoma County is with Buckaloo. I think what we felt the funding, it has multiple funding sources. The main one is Medi-Cal for their mental health services through contracts with Sonoma County Behavioral Health. They also have an MHSA grant through Sonoma County Behavioral Health. And the housing is provided by HUD federal grants. They also pay shared rentals. They have their own fundraising activity and fund developments. So some of the pandemic has reduced some of this county-based outcome measures, and the degree of funding is very successful, but it has placed some restrictions on it. So again, they have in Sonoma County independent living, they have supported housing programs, they have FAC, which is forensic conservative community treatment programs, and transitional age youth. And so it's a very impressive outfit, and they did a great job in presenting the material. But it was not just a slide presentation and showing slides here and there. Here's the outside. Here's what the facility looks like. Here's what it looks like inside. Here's some of the people. It was really excellent. And that would be a program. I know Bill knows them quite well, but Buckaloo, maybe if we could ever have them present at a mental health board, a brief presentation, because I think you'll be impressed with the diversity and richness of the program. So do you think so, Bill, or that would be helpful? Or?
Yeah, they're one of our primary providers along with Progress Foundation. They're really a part of our mental health plan, and they're a good partner.
No, I was really impressed.
That sounds like more than a site visit. It sounds like a program overview.
That's what it was, because we started out just Manor House, what I wanted to interview them and talk about, but then they included all the programs. So it was quite extensive.
Yeah, pretty interesting.
So Kathy and I, we prepared, the form we'll present or distribute, Tori will, to the mental health board members. But there's no secrets with this. It's open, to anyone who wants to read it. So we prepared both the reports.
Bob?
I'm just repeating, Mary Frances had asked 2 questions on the chat about Progress Sonoma. She was wondering how people are referred to their program and who may refer them.
So if I remember right, they are all referred
From
through
Access. I think it's
Access into Sonoma County Bureau of Health.
And it's from the county as a source of their referrals. Which is true, actually, for the Buckaloo programs, it's through the county. Is that correct, Bill? Am I saying?
Yeah, programs like our crisis residential programs are generally routed through the CSU, through the Crisis Stabilization Unit. It's part of that continuum, and so the referrals come from there. And then referrals to our housing programs, generally if they're new to us, they're coming through Access, or if we've had contact with them in another program, they're coming into the adult case management where they're being assessed and referred to programs that have resources.
Again, as Bill says, the county controls the admission of the patients, Sonoma County patients, to both the facilities. So that's all I have. Both were about 90 minutes long. And we'll be working with Bill and continuing identifying other programs that might be beneficial to review and see if this is helpful.
Okay. Okay, so did you have Carol or Bob have anything new about the jail?
I defer to Carol.
Carol?
I think we still would like to do a panel of lived experience, individuals with lived experience, or potentially a follow-up to a study that's being done on barriers to re-entry. I believe that should be finished by the end of the year. So I'll connect with you as to when I think that will be ready, because I think that would be something that, at minimum we can just share the report, but it might be something that people would be interested in to hear from individuals themselves who've been through the system. And maybe a follow-up at some point as to how, I don't know, Bill, if you know how, if they've broken ground on the new unit at the jail. I know that's the Sheriff's Department, but my understanding was that they were going to start in April. I'm not sure if that happened or not.
Yeah, we've not been notified of that.
Okay. Okay. Yeah. So keep you posted.
So if there are no other questions on that, we have a couple of things that are well, the nominating committee.
Yes.
For nominations.
Yeah, the nominating committee, Bob Cobb and I met. We had 2 recommendations. first, with Kathy, we're able to convince her that it would be nice to do one more year and to serve the board. She's done such a fabulous job. And so we recommend that Kathy Smith be the candidate for chair. And Peterson, we recommend to be the candidate for vice chair. And Peterson is willing to help out Kathy because she has another task too in the community, but as more a team function. We mentioned Quality Assurance Committee, Peterson. That would be one of the things vice chair would do. But I think the two of them will make a great team. Again, and we look forward to it.
Okay, and I accept that. Peterson. You accept that?
As much as I was at the vice chair, I didn't do much for the year, and it was not a typical year of the board and how it functioned. And I would love to be more involved. So in the event that I would like to be the chair, that I have some actual hands-on doing the work. So I'm not saying I would want to, but in the event I would consider it. So I'd very much like to be more involved in working along with the chair.
Yeah,
that's music to Kathy's ears.
Yes.
Yes,
I give you I'll email you a job tonight. And I really seriously, I know that you've been very busy this year, but I would like to have you attend the QIC with me. That's definitely something that I'd like to have you more present at. So, okay, so I'll give you more information on when that's happening, and I have stuff for you to do. Okay.
Kathy,
Yes.
just to kind of wrap the package up, these are the present nominations for the office. We'll be voting on them in June at the June Mental Health Board meeting. This does not mean that if I want to not discourage anyone, if there is someone else who has interest in serving in either office, the nominations would still be available to be done from the floor or from your screen in this case, up until the time of the election. And
that
so
certainly has happened in my tenure on the board, where
I'm sorry, say that again.
that has happened in my tenure on the board,
Okay.
where one person was nominated and then there was a nomination from the floor, and the nomination from the floor was elected. So
Interesting. Okay. So it's potentially possible, but the June meeting will be when the voting will take place.
yes. Okay, so be sure to put that on the agenda, Tori, so I don't forget to say something. I had a request for a representative, a volunteer from the Mental Health Board for an upcoming RFP evaluation panel. And it is for, I think it was emailed out today, but it's for the mental health block grant first episode psychosis set aside, which is looking for a CBO, an acronym. I'm not sure of what CBO stands for, although I'm sure people do know.
Community-based organization.
Thank you. It's seeking a community-based organization to provide services to individuals who are experiencing or have experienced a first episode of psychosis. The proposal should support an FEP program design, first episode of psychosis design, that includes early intervention, coordinated specialty care, and a team-based approach. So They received the proposals today and they're looking for somebody who would like to sit and evaluate the proposals. The time commitment would be an introductory meeting about an hour long, the offline reading and scoring of proposals, and a final session to come up with a recommendation. So 2 to 4 hours. So if anybody interested in doing that,
I just have a question on it. Is there a time frame as to when the completion of that process from the volunteers' perspective would be?
he doesn't have a particular time frame. I know that they did receive the proposals, and if you are interested, I can give you his contact information and you can get some more information directly from him. It's Bruce Robinson. Bruce Robbins.
Okay, why don't you send that to me? And I'm not sure that I can commit to that, but I would like that information to get a sense of the length of this process.
Okay, I will get that to you.
Thank you. That might also,
Kathy?
if I find out, it might also provide an opportunity to give feedback through Tori to everyone else, if the time frame is relevant.
I also wanted to let you know that I did email that request out to the board, so check your email boxes.
Yeah.
And Vanessa volunteered as well and reached out to Bruce. So we do have her, she agreed to volunteer. And then everybody else should have it in their email boxes just to check and respond back.
I was interested, but the problem is UC Davis is going to be applying for funding in the early psychosis program. That'd be a conflict of interest. So,
Okay, so Vanessa has reached out to Bob. Perhaps you and Vanessa could talk, and I don't know whether you could both talk to Bruce Robbins, and I don't know whether he wants 1 or 2 people, but you guys can work that out, okay?
Yeah, sounds good.
Okay. And speaking of Vanessa, welcome, a new board member appointed today.
oh, congratulations.
Hi, everyone. Thank you so much.
Yeah, so you'll have a chance to really introduce yourself. We have our retreat coming up this weekend, and hopefully you'll be able to join us at that. It's from 9 to noon on the weekend, and you can give us a greater description of yourself and so we can learn all about you and what brought you to the board. But welcome. It's great having you.
Thank you so much. And I look forward to that. I'll introduce myself more formally then.
What district do you represent, Vanessa?
District 3.
Okay. Welcome.
Thank you.
Okay. Okay. Volunteers and the retreat.
Kathy, one comment.
Yes.
In our bylaws, it says we need to have at least 3 people on the board who represent consumers and 3 who represent family members. And so currently, you're the only family member represented. And we have now some consumers, but of the 3 openings, 2 should be family members if we satisfy our criteria. I guess half of the members should be family members or consumers, but we're very heavily represented by the community.
Yes, this is a unique time, I think, because this is the first time that we've had a full slate of consumers and not family members. I don't know, Betsy. I don't know if Betsy's still here, but with her conversation today about her younger brother,
Yeah, she would qualify.
it's possible that she could, transfer her membership to be a family member, because it sounds like she truly is. Okay. Okay, so we are, I know that we have a vacancy still in District 4 and one in District 5. And we're excited to have Vanessa. So I'm not sure. Let's see, who is our District 3 person other than Vanessa? I have that printed out. District 3 is Michael Johnson. He's not here either. So that's one of your jobs that I'm going to set you to, Peterson, is to talk to Chris Kersey about exactly who our representatives are from District 3. I know Vanessa and Michael. Okay, so it looks like, okay, so we have the retreat on Saturday, and we'll be looking at really, I think we're looking at what what we learned from the presentation for Dr. Dominguez, and the presentation by Wendy Wheelwright, and the presentation by Sarah Rock. We had 3 very strong presentations, and what do we do with them? And I'm thinking that we're certainly going to be looking at, we already have a bunch of statements that we read at the beginning of the meeting. And I think that we need to look at those and make sure that that they are what we want to say at the beginning of the meeting. And rather than add a statement, we may want to revise either the mission or the vision or who we are. And Tori, are you going to be helping us out at that? The retreat? Thank you.
Yes, ma'am.
I'm sure you wouldn't put down a date that you couldn't do, but Carol.
I'm just wondering if we have given an invitation to Susan Castillo, who's our new kind of racial equity staff member on the Sonoma County Behavioral Health. I'm not sure if that would be appropriate, but it may be a good way to get to know her, and I'm sure she'd have a lot of good information to share with us, if that's what the context is.
An invitation would be a good idea. It hasn't been extended, but we could certainly do that. Susan used to work very heavily with the board. She was our liaison at one point. So it would be nice, to get reacquainted with her. It would be reacquainted for me, but most of you weren't on the board at that point. So,
Supervisor, you might not say she has to stay for the entire retreat. Pop in for an hour or so.
Say that again, Bob.
Rather than expectation that she would be there for the entire retreat, it might be more saleable if she could, come in for an hour or so and discuss. We could include her in particular activities or discussions that are relevant, but so she isn't spending her entire morning on the retreat.
I will let you know, she's currently still in her previous position, so she's transitioning out. And we don't expect her to fully make the transition until June. So she's really not working in her current role yet. She's not had her chance to get her feet under herself.
So I will email her and extend the invitation I think that she would appreciate the invitation even if she can't come.
And she's always got, I mean, she's got great background. She can talk about this and talk about what she's been thinking about and such. I just wanted to give you the context.
I totally appreciate and always have appreciated when she was in charge of the outlying areas. Her reports to us were incredibly detailed. And I know that she puts, a lot of effort into the work she does. And that was always appreciated. And it's missed now. I mean, we're working harder getting our outlying areas to, represent. So I will extend that invitation.
My experience with her when she was liaison to the board was there really wasn't any question that she didn't already have experience in answering. So if you do have any questions about what's going on, she's an excellent resource.
Yes.
I did have a question. Can Tori send us a copy of the script that you use at the beginning of the mental health board before we come to the retreat, so we might have a chance to glance at it?
The cheat sheet.
There you go.
Yep, that's how she sends it to me. Here's the cheat sheet.
Yep.
Okay.
Kathy, I have a quick question, if it's okay. Kind of backing up a little bit. Could you give the definition for, family member, consumer, and, what each member, the board is supposed to be comprised of? I'm not exactly sure, and I'm thinking Vanessa might not know, and maybe others as well.
Right.
So we're just not sure.
Sure. So in the bylaws, it's definitely laid out that we can have 15 members. Half of them have to be either consumers or family members.
That would be 8, right, Kathy? Eight members need to be family members or consumers of the 15.
Yes, 8. It specifies the number because we can have 15 members plus 1 board of supervisor makes 16. So that makes 8 people have to be family members or consumers. And a minimum of 3 are family members. A minimum of 3 are consumers. So there's a little wiggle room there, but that's the way that the boards all across the state are set up. That answer your question, Tori?
I think so. And just to confirm, a consumer would be someone that is actively participating in behavioral health treatments, or is that incorrect?
Somebody who has lived
experience.
Oh, lived experience. Thank you. Thank you.
Okay. Any other questions? Okay. I don't think I have anything else. I will I can send out that description of, well, possibly if you could send out the bylaws, if you have those electronically, Tori, then we can refer to them at the retreat. The bylaws and the cheat sheet. Yeah. And do you have the Jamboard?
No.
Okay, I think I do.
Okay.
So I'll have that. Okay.
I think we were looking for that. Mhm.
Okay.
And yeah, I'd just like to put a word in. I'm really great. I'm really glad we've got a full complement of consumers at the moment, but I'd very much like to see a little more diversity if we can find it, and if we can actively pursue that. I think that would be awesome.
Ethnic diversity?
Sorry?
What kind of diversity? Ethnic diversity? What
Yeah, I see a lot of white faces.
Yeah.
I'd like to see a few more people of color, or Asian, or you know, maybe outreach through Sonoma County Indian Health, or maybe through Humanidad, for a few more Latinx families.
So what I did was I sent the information that we were searching for new board members through Los Cien,
Oh, Cien. Mm-hmm.
which has contact with a bunch of the Hispanic community, a lot of the Hispanic community, and some of the other like Indian Health, and I did do some outreach.
Mm-hmm. Yeah.
But we can discuss that. You know, the outreach and
At our retreat. Okay. Yeah. Yeah. I did try myself as well, but it's really hard. Yeah.
It is, and I'm totally amazed that we have you know, consumers, because that was very, very difficult for a long time. So okay. Anything else? Okay. I think that we are, well, I didn't quite go over this time, but I got closer. Okay. So I will be contacting you, Peterson, and I will send the information. You already have the information, Bob Cobb. You can check with Bruce Robbins. You've got his contact. Okay. Perfect. So do I have a motion to adjourn? Okay, Carol and Bob Hale. One motion, the other seconded. The meeting is now adjourned. Thank you, Vanessa, for joining us.
Thank you, everyone.
Yeah. Thanks, everyone.
Thank you.
Thank you. Have a good night.
Look forward to getting to know you. Bye.
Hi, everyone. Have a good evening.
Bye.